Hi, everyone, and welcome to our Friday session. Today, we have a journal club. We have a very interesting topic, the role of molecular markers in Bethesda 5. Usually, we use it for Bethesda 3 and 4, so we'll see what's the role of these markers in Bethesda 5. We have two prominent guests with us. First, we'll have the journal club. John will present a study, and after that we'll have a discussion, and after the discussion by Trevor Angell we'll have Q&A. During the session you're welcome to write questions. You have a Q&A button in the Zoom app, and later we can read your questions. So first let me present our two guests. So first, John Skaugen, sorry for the name. He's received his MD degree from the McGowan Medical School in Houston, Texas in 2016. He completed residency in anatomic and clinical pathology and fellowship in molecular genetic pathology at the University of Pittsburgh in 2020-21. He joined the Department of Pathology in the University of Pittsburgh as an assistant professor in 21. And in his research interest includes studying the molecular pathology of thyroid cancer and CNS tumors. After the talk by John, we'll have a discussant, a well-known thyroidologist, Trevor Angell from California. He's an assistant professor of medicine in the Division of Endocrinology and Diabetes at the Kirk School of Medicine at the University of Southern California, Los Angeles. He received his MD and completed internal medicine and endocrinology fellowship at the Kirk School of Medicine. Later, he joined the endocrinology faculty at Brigham and Women's Hospital and Harvard Medical School in Boston, conducting clinical research in thyroid disease before returning back to Southern California. He's currently Associate Director of the USC Thyroid Cancer and co-director of the USC Peter Singer Thyroid Symposium. His clinical research interest focuses on diagnosis and management of thyroid nodules and cancer, and he serves on the editorial board of several leading journals, including Thyroid, Clinical Thyroidology, and more, and he's the chair of the ATA Patients Affairs and Education Committee. So it's a pleasure to have you both, and we'll start with you, John, and the stage is yours, please.
So this is me, John Skaugen. I'll be talking about the paper that we recently published, Performance of a Multigene Genomic Classifier, Thyroid Nodules with Suspicious for Malignancy Cytology. So this is available open access in thyroid for any interested parties. I do not have any financial disclosures. And so what I hope that you'll get out of discussion of this study is that you'll see that molecular testing performs well in thyroid nodules with suspicious for malignancy cytology. Molecular testing can predict the histologic outcome and identify some potential therapeutic targets. And the molecular risk groups correlate with cancer recurrence risk in these nodules with suspicious for malignancy cytology, or Bethesda 5. So I'll briefly go through the background, the materials and methods, and then of course the results, conclusions, and a brief discussion of where do we go from here. So as many of you know, thyroid nodules are common. Many of them are detected incidentally, and a large proportion of them are benign, thankfully. And so thyroid FNA is done for a variety of factors: size, clinical and ultrasound characteristics, and the end goal is to determine the chance of malignancy, and if a patient needs surgery or if they can be safely observed. So based on these FNAs, the cytology is classified into 6 categories based on the Bethesda system. And so most of these are benign, and then the next most common would be the malignant diagnosis, typically papillary thyroid carcinoma. And then we have these categories in the middle, indeterminate. So we have Bethesda 3, atypia or follicular lesion of undetermined significance, Bethesda 4, the follicular neoplasm, and the focus of this talk is suspicious for malignancy or Bethesda category 5. So in these kind of middle indeterminate categories, the management recommendations have ranged from repeat sampling, now moving into more of the era of molecular testing, or then surgery or diagnostic lobectomy. Most of the clinical studies, so there are several larger molecular panels out there for testing thyroid nodules, and most of them have been evaluated in Bethesda category 3 and 4. Those are much more common. And so most of the data is there. There's really not a lot of data for Bethesda 5. There's been a handful of cases for each of the clinical validation studies for these large panels. For our specific panel, ThyroSeq, there were only about 10, and a couple of the other two have had, in the range from around 20. There have been a couple studies that looked at larger numbers of Bethesda 5, as well as some Bethesda 6, one by Rick Payne at McGill in Quebec. But these didn't have a lot of outcome data. And so there's not a lot that we could glean from those at this time. So this was just a brief, summary. This was the clinical validation that mostly was Bethesda 3 and 4 with 94% sensitivity, 82% specificity, 97% negative predictive value, 66% positive predictive value, and a 28% cancer or NIFT-P prevalence. To touch on the molecular risk groups, this was another recent paper that looked at the specific molecular alterations and risk for distant metastasis in differentiated thyroid cancer. And so this is where I'll talk more about this in a few slides, and you'll see there's a low risk category, medium risk or intermediate risk, and a high risk. And so this you'll see will correlate and in the discussion of the molecular risk groups. So what we sought out to do, this actually started as a fellowship project for me, primarily initially to determine the performance characteristic of ThyroSeq version 3 in these nodules with suspicious for malignancy or Bethesda 5 cytology, because that was not well established. Additionally, we looked to evaluate the ability of molecular testing to predict the tumor phenotype or the histologic outcomes, as well as predict the risk of recurrence in this Bethesda 5 category. So we looked at all FNA samples with suspicious for malignancy cytology within our hospital system, cases that had a known surgical outcome and had ThyroSeq testing or material that could be tested. We calculated the TIRAD score, the ATA risk group. This was done by one of our endocrinology fellows and endocrine surgery fellows. And then the thyroid cancer recurrence was evaluated. So these were patients with molecular testing positive, a cancer diagnosis, because you can't have recurrence with benign disease typically, and then no metastatic disease at presentation. So metastatic disease at presentation, you're not eligible for recurrence. So the ThyroSeq cancer risk classifier was applied to all of the test positive samples, and this gave us the molecular risk group. So as I alluded to with that previous study by Lynn Yep, the molecular risk group low, these are our RAS-like alterations, mostly RAS mutations, as well as the focal chromosomal type copy number alterations. These are all typically follicular patterned tumors. The intermediate group is the BRAF V600E-like alterations, and then genome haploidization type copy number alterations that are seen in Hürthle cell neoplasms. And then the high-risk group are those with a TERT or TP53 mutation in combination with one of those other primary drivers, like a RAS mutation, BRAF mutation, or fusion. So for those interested, initially we identified about 258 total samples in the study period with suspicious for malignancy cytology. A handful were excluded because there was no known surgical outcome. And then there were about 100 or so cases that had no molecular testing done at the initial time of FNA. And then there was either no sample collected for molecular or the sample was no longer available. And then a small number of cases where testing failed. And so that gave us a final cohort of 128 patients to evaluate. For any of the discrepant molecular testing, so testing positive and histologic outcome benign, or vice versa, molecular testing negative, histologic outcome cancer. The slides were reviewed as they were available. And then for this interesting group that were molecular testing negative, that kind of was a big interest for us of, what do you do when it's negative in a Bethesda 5? Those that were cancer by histology, these underwent a blinded slide review by one of our thyroid pathologists here. And then molecular testing of the resected tumor was done for a subset of cases. So there were a few that were not available, which I'll touch more on, but we did those on those with available material. So getting into the results of the study, like I mentioned, the cohort was 128 samples. There were about 70%, 89 of them had preoperative molecular testing. So this was done clinically at the time of the initial FNA. And then there were 39, so about 30 to 31% that had postoperative molecular testing. So that was testing that was done by us as part of this study, where testing was not done clinically and not available at the time of surgery. Overall, we had about 83% cancer prevalence out of these 128 cases. And overall, 100 were molecular test positive and 28 were molecular test negative. And you can see here that group, the sensitivity was about 90%, specificity 77%. The negative predictive value, not surprisingly, was lower compared to the Bethesda 3 and 4 group with the high cancer prevalence, 61%. And then also, not surprisingly, the positive predictive value was high at 95%. So for those familiar with the Bethesda system and some of their estimated, risk ranges for cancer and NIFT-P prevalence, you may be thinking to yourself, 83% is a pretty high cancer prevalence. And we thought the same thing. Talking to our cytologists about this, they do try to have pretty stringent criteria for calling suspicious for malignancy. But the expected range based on the Bethesda system is anywhere between 50 to 75%. And so based on this, because we're not the only ones utilizing the test, we use Bayes' theorem to estimate the negative predictive value and positive predictive value within these ranges to try and get a better idea potentially of the residual cancer risk, possibly in a more wide cohort. Obviously, these are just estimates. And so the negative predictive value in this range would go from 71 to 88%. So for our cohort specifically, again, 61%, and positive predictive value 80% to 92% for our cohort was 95%. Again, which makes sense as these values depend on cancer prevalence. So for our 100 cases with molecular testing positive, we had 95% were cancer. Again, gets us to that 95% positive predictive value. The 5 benign cases, 4 of those were actually Hürthle cell adenoma. And they can have similar molecular alterations to Hürthle cell carcinoma. It can be difficult to distinguish those. Interestingly, it did not really depend on size. We had a couple of these that were quite large, 6 centimeters, I think, at least for one. And then the other 2 were smaller, under 3 centimeters. Most of these, not surprisingly, had BRAF, mostly V600E mutations. 20% had RAS mutations, most commonly NRAS. 11% had gene fusions, and 8% had copy number alterations. We did have 12% with TERT and or TP53 mutation, again, in combination with one of these primary driver mutations. And we also had 2 cases of metastatic renal cell carcinoma that had a VHL mutation and essentially no thyroid markers on our test analysis. And then there were 10% with potentially targetable alterations, so those NTRK fusions, RET fusions, ALK fusions, and 1 anaplastic carcinoma with BRAF V600E. So this is just the ONCA plot that's available in the paper. Again, you can see most of the BRAF V600E. These are going to be your classic PTC. They fall into the intermediate risk group mostly, except for the subset that had a combination TERT mutation. You can see 1 anaplastic carcinoma, both tall cell variant papillary thyroid carcinoma here. Some other classic PTCs with RET and NTRK fusions. And again, a lot of the follicular variant PTCs in this kind of RAS group, many of which are low risk than those with combination TERT mutations like we discussed. So the molecular testing negative group, this was 17% benign. So again, that's 61%. That's the negative predictive value. And 11 of these cases were cancer. So we had, of these 11 that were cancer and molecular test negative, 9 of them, we had slides that were available for review. So reviewed by myself and Dr. Yuri Nikiforov, and then a blinded review by Raja Sigala. And all were confirmed to be cancer or at least NIFT-P. And then 8 of these were successfully tested on the resected tumor for molecular testing. 1 of them unfortunately failed. And 4 of these were positive and 4 remained negative. So of the 4 positive, 3 had BRAF V600E mutations at quite high level. And then another had a sort of lower level TERT promoter mutation and some gene expression alterations. The 4 negative cases essentially had nothing. Again, this is kind of the group here. And so these are the benign diagnoses, mostly had either no alterations or low-level KRAS or a couple with low-level EZH1, typically seen in hyperfunctioning nodules. And in these cases that were negative, a few that were not available for testing and slide review, 4 that were what we would consider the true false negative, so no alteration identified by the test and confirmed to be cancer. And then again, these 4 that had most likely related to sampling, a clear molecular alteration in the tumor that was not represented in the sample sent for molecular testing. So the other interesting part of this was, again, the molecular risk groups and cancer recurrence. So overall, we had 20% in the low risk group, 66% in the intermediate risk group, and 14% in the higher risk group. So for the recurrence analysis, there were 8 cases excluded. So 5, as I mentioned, had benign histology diagnosis. And then 3 cases had metastatic disease at presentation. Again, that's 2 renal cell carcinomas, and then 1 anaplastic carcinoma had metastatic disease at presentation. So for our follow-up period, the mean follow-up was about 51 months, ranged anywhere from less than 1 month, a patient who died very quickly, which I believe was an anaplastic carcinoma, and then 1 patient actually with follow-up, I believe up to 540 months, so quite a long follow-up that was available. So overall, there were 12 patients, so 13% of this group, 92 patients. 11 were structural recurrence, and 1 was biochemical only recurrence. So again, that was defined as initial decrease of the thyroglobulin and then increase later, but no identifiable structure disease on extensive imaging for that patient. So broken up by the molecular risk group, the high risk group, 6 of those cases, which was about 55%, had recurrence. Another 6 were in the intermediate risk group, so that was close to 10%. And then the low risk group for this study did not have any recurrences, at least for the follow-up period here. And these were statistically significant between the high risk and intermediate and high risk and low risk. So the estimated 36-month free survival was 56% for the high risk group, 91% for the intermediate risk group, and then of course 100% for the low risk group with no recurrences at this time. So this is just a view of that, the Kaplan-Meier curve that you can see are low risk, intermediate, and the high risk group that has the worst recurrence-free survival. So the things that we learned from this study, we found that molecular testing performs well in thyroid nodules with suspicious for malignancy cytology. Based on the Bayes theorem analysis, the estimated residual cancer probability for these molecular test negative, again, the group that we were kind of hoping to get a little bit more information on, could potentially range between 12 and 29%, so not an insignificant residual probability of cancer. And then approximately half of the false negative molecular testing results were due to most likely limited sampling. Again, that was no molecular alteration in the molecular sample and a clear high level, in most cases, molecular alteration in the resected tumor. We also found that molecular testing can predict histologic outcome. Again, the RAS mutations that associate with follicular patterned cancers, BRAF mutations that associate with more of the classic PTC or tall cell PTC, and identify potential therapeutic targets such as NTRK fusions, RET fusions, ALK fusions, BRAF V600 mutations in anaplastic carcinoma, and now really any advanced cancer with the more recent FDA approval. We also found that the molecular risk groups correlate with cancer recurrence in these nodules with suspicious for malignancy cytology. So these the molecular alterations identified can be further analyzed to develop these molecular risk groups and give the potential recurrence risk. So then the question is, where do we go from here? The next steps are hopefully some clinical utility studies. So what impact will these molecular risk groups have on surgical management? I know we've talked about this within our own group, some discussion at the ATA meeting where we presented this recurrence data. And so, that's going to require some additional clinical studies to see what impact does it have. Does a high risk molecular profile do those patients do better getting total thyroidectomy, other sort of management versus more limited? Do low-risk patients, are they acceptable to get lobectomy? And so those are all things that still have to be determined, and hopefully Dr. Angell will discuss, and I imagine people will have questions. And then additionally, more evaluation of the performance in other patient cohorts. So again, our cohort had quite a high cancer prevalence, and so it will be interesting to see, hopefully over time, people analyzing in their own Bethesda 5 or potentially Bethesda 5 and 6 cohorts to look at that performance and see, again, especially that residual cancer probability that was estimated from our data, to see where that kind of ends up. And, then once that's established, what do we do from there? Does a patient with a negative test result, is that residual probability still too high? And from there, so there was actually one abstract that was presented at ATA meeting this past year by Max Shum et al. So Michael Ye and Masha Livitz from UCLA. And so this is just kind of a quick summary, and they were looking at Bethesda 5 and Bethesda 6 nodules. And again, they found, somewhat relatively similar results as far as recurrence data. So their low risk group did not have any recurrence as well in their follow-up period. Their intermediate risk group, I believe, was relatively close to our 10%. And their high risk group actually was, I think, even higher cancer recurrence rate than ours at 55%. So it will be interesting to see the more final results of this study in the future, and hopefully see some from other institutions. So these are just some references. I'd be remiss not to thank Dr. Nikiforov and Dr. Nikiforova mentoring me through this in my fellowship and helping me get it across the finish line. Dr. Wald is our assistant lab director, of course, all the lab staff that did this, and our administrator who helped me facilitate this during my fellowship. So again, no disclosures, and then I'm happy to turn it over to Dr. Angell.
All right, terrific. Hello to everyone. It's a pleasure to be here. Thank you to the organizers for the invitation and for providing this educational forum. Dr. Skaugen's summary of the article was excellent, as I would have expected, and I want to congratulate him and his colleagues on the work. I don't have any disclosures related to this talk. So I think there's a lot of details to dive into. I think people may do that in the Q&A, and I think my comments will be a little bit more broad and hopefully interesting. I'd like to spend the time, first kind of giving an overview conceptually of what molecular testing can do to try and optimize our management of thyroid nodules and thyroid cancer. And then focus a bit on why suspicious for malignancy, Bethesda 5 would be a particularly interesting category to dive further into as far as using molecular testing to guide our decisions. Then, highlight a little bit in this study where I thought the key parts were, both in terms of the findings and maybe a couple of the limitations. And then lastly, just kind of wrapping up about where we might go from here. So thinking about, molecular testing in our management of thyroid nodules and cancer, what are the goals, at least from my perspective? And one way to think about it is, going from the idea of, treating all the cancers we find maybe in a one-size-fits-all manner to really how do we treat cancers optimally? And so if we think about an increasing risk of really relevant thyroid cancers, we now have a number of modalities that can assist us with this. Starting with ultrasound, whether it's American College of Radiology TIRADS or American Thyroid Association, we know that there are a number of features that are both associated with malignancy and, likely aggressivity, because, a lot of the hallmark features of malignancy may be associated with papillary thyroid cancer, BRAF mutation, and certainly evidence of extrathyroidal extension or lymph nodes would be, markers of more aggressive disease. And these things don't track perfectly, but they certainly have correlation. Next, we have, cytology, which, certainly guides a lot of our management. But in general, we could say also that if we're thinking about cancer, suspicious and malignant cytology, likely harbor some more aggressive malignancies than perhaps atypia or suspicious for follicular neoplasm many times. And so from a treatment standpoint, we sort of land now at a place where we are going to likely observe benign nodules, at least from a malignancy risk standpoint, and maybe a few atypias, more and more based on diagnostic molecular testing. And then for other tumors, we may be in a lobectomy versus total thyroidectomy, and there may be really imperfect decision-making there. And for the purposes of this, we're really focused on the Bethesda 5 suspicious category. And so we're on top of that, we're overlaying this molecular data and again, stratifying this by our risk of really what are the important malignancies. As John was saying, up to really kind of multiple significant mutations that tell us when there's a higher rate of aggressiveness. And so fundamentally thinking, can we use this data, for example, to really stratify people surgically as a first step into those that need more or less aggressive surgical treatment? And then moving on from there, how do we use this to guide cancer management? This was from a commentary by Jeff Crane and colleagues, and was specifically geared towards the expression atlas that's offered by Afirma, but I'm really just going to talk about it in a general sense for molecular testing. That, when we can tailor treatment based on molecular data, we may be able to first infer malignancy risk, maybe NIFP, but then secondarily get prognostic data about recurrence risk and what kind of behavior the tumor may follow. And then lastly, as was mentioned, we have the opportunity to get targetable mutations and guide systemic therapies for those that need it. So really, again, turning towards optimization rather than one-size-fits-all approaches. So why focus particularly on this category? And I think just to step back a little bit to the history, we can look at all the flow diagrams that have been created in various versions of the American Thyroid Association guidelines. And so going back to earlier editions, we can see that really suspicious for malignancy and malignant had the same management, surgery. Moving forward, still the same thing, surgery. In the most recent 2015 guidelines, we see that suspicious has been split off sort of for the first time. But we can just see kind of what the current recommendations are. It is the case that surgical management should be similar to that of malignant cytology, depending now on some risk factors and mutational testing if performed. Remember, this is back in 2015. And then after consideration of clinical and sonographic features, mutational testing for BRAF or a 7-gene marker may be considered if such data would be expected to change management. So I think we can see we've come a long way in terms of our expectation about molecular testing from 7 genes to many more. And also the question of, would such data be expected to alter management? I think more and more the answer is going to be yes. So if we look at evolving ideas since those guidelines, firstly, we can look at the Bethesda system and our expected malignancy rate, as was pointed out, but really seeing the recommendations between that and malignant cytology are similar, but also, some uncertainty with lobectomy and total thyroidectomy. And so as far as the initial application of molecular testing goes, we had earlier versions of oncogene testing and then gene expression classifier. So this is from the 2012 New England Journal paper by Alexander et al. For the gene expression classifier. And I just want to highlight the idea that because the pretest probability of malignancy is high, in this study 62%, the negative predictive value is 85%. And in a era where molecular testing more and more was seen as a way to rule out malignancy safely and avoid surgery, testing of Bethesda 5 nodules did not receive very much attention, I think, for quite a while. Next, we have, really the identification of NIFP, reclassifying encapsulated non-invasive follicular variant of papillary thyroid cancer, and the implications of this across Bethesda categories. And I've bolded here Bethesda 5 to show that this is a category where NIFP may often be expected to reside and would really significantly modify malignancy risk if you consider it to be non-malignant. Essentially, the risk would go down quite a bit. And so, in the existing table for the Bethesda category, we can see there's, 2 risk of malignancies implied depending on what you consider NIFP to be. So now we have sort of even greater uncertainty in this Bethesda 5 category in terms of optimizing management. Finally, I would want to highlight some data that was done by Dr. Wu a few years ago with Eric Alexander's group. And what this essentially shows is that the Bethesda category moving from Bethesda 3 to 4 to 5 has some association with American Thyroid Association risk of recurrence, low, intermediate to high. And if you look at Bethesda 3, you can see that it predicts to some extent lower aggressivity. If we look at Bethesda 6 and malignant cytology, we can see there's association with higher aggressivity. And again, Bethesda 5, even though I think you can see a trend, there's a bit more spread. Those boxes are a little bit more similar across. So again, more uncertainty in what kind of tumors we're going to get out of Bethesda 5 cytology, and sort of an increased need to really have good prognostic tools. And finally, I'll say, since the last American Thyroid Association guidelines, the Joint Commission on Cancer Staging has changed, as we well recognize, and this has essentially downstaged many patients to lower stages. And so perhaps old views on the need for aggressive treatment may be changing. And so just because someone has a Bethesda 5 and may have malignancy, we aren't automatically going to bring out the same treatment for everybody, regardless of maybe some things like minimal extrathyroidal extension or lymph nodes based on the way we perceive staging. So let's turn to this study for a little bit, using ThyroSeq version 3, a very robust platform for looking for genomic alterations. And this was certainly well reviewed. I won't belabor the point of the methods, but looking at the roughly 78% that were mutation positive, very high likelihood of malignancy, I think that helps a lot in a category where that risk can be relatively broad. And then 22% that were test negative, where you had roughly 40% malignancy. And I think that really highlights the point I made earlier, that when we look at pretest probability being high in a category, it gets quite difficult to rule out cancers. So focusing in on, what I felt like were some of the really key findings, this from the studies table. So if we look across those risk groups from low to intermediate to high, and we look at American Thyroid Association risk of recurrence categories, you can see a clear correlation that low risk really were less aggressive tumors, and in a graduated way, you had some increased risk, and then moving up to high risk molecularly certainly helped, my apologies, certainly helped predict more aggressive pathologic features, which I think is important. The high-risk molecular group is also associated with older age, larger nodule size, greater sonographic risk features as well. And then looking at the assessment of recurrence, similarly, really graduated and steeply rising risk for recurrence with greater molecular alterations. This was the diagram that was shown previously. And to me, it looked familiar. If it looks a little bit familiar to you, we could compare it to some other data. This from Mingjiao Xing's group, sort of landmark study from several years ago related to BRAF and TERT mutations in papillary thyroid cancer. It really showed decreasing survival steeply when you had the duet of BRAF and TERT mutation. And similarly, I think identifying some high-risk mutations in this population that similarly predicts a worse outcome. So this is, particular to a cytology and a different group, but I think nicely recapitulates what we expect from prognosis. What about, at least some high-level limitations that I saw? So certainly this seemed like a particularly high-risk population. As was noted, the prevalence of malignancy was relatively high at above 80%. And you had some, particular histologic types in there, a couple of renal cell metastases and anaplastic thyroid cancer. And so, that might not be seen in all groups. As I pointed out before, we might expect some prevalence of NIFP in the Bethesda 5 cytology, and there weren't very many of those seen as well. And so, could this be due to just referral patterns at a large center, perhaps? As was noted, could this be the way in which pathologists carefully evaluate specimen? In recent times, in order to maintain very high accuracy for the Bethesda 6 malignant category, and not wanting to get anything benign in there with NIFP, some pathologists may have shifted how they read slides a little bit, but this study covered a much broader time period. So I don't think that's particularly the explanation. And then finally, I would think a word of caution in this study regarding the implications for treatment and the sense that more treatment for something that's more aggressive is necessarily going to lead to better outcomes. And one way that I'll highlight that is with this figure from James Fagan's New England Journal review. And if we look at the left hand column with BRAF V600E, obviously a marker of more aggressive tumors. We know that this enhances MAP kinase signaling and creates dedifferentiation and potentially less radioiodine avidity, due to loss of sodium iodine symporter and other reasons. And so just because someone has more aggressive molecular markers, does that mean we should be applying total thyroidectomy and radioactive iodine treatment? There may be underlying biologic reasons that might not necessarily lead to better outcomes, and we need to be careful about the conclusions that we draw. I'll point out another way in which I think this should be thought of, and this is from Dr. Robenstock's group. This is a meta-analysis of autopsy studies, and we can see the expected relatively notable prevalence of occult thyroid cancers found in autopsy studies. But what was notable in this recent study published in Thyroid was they looked specifically at higher aggressive pathologic markers and found that even in these patients with occult DTC, there were rates of multifocality, minimal extrathyroidal extension, lymph node metastases, and lymphovascular invasion in people who passed away without recognition that they had thyroid cancer. So even identifying some adverse pathologic findings may, we may have a hint of caution that this is necessarily something that it requires extensive treatment to benefit someone in their life. So on top of the molecular mountain, where do we stand? I think we still have some hiking to go to get to the summit, but we're certainly making progress. So where do we go from here? I think this really helps us in thinking that we should be recognizing the predictive power of molecular testing in cytologies that suggest cancer, and not just those Bethesda 3, Bethesda 4 categories. I think moving forward, I think it would be very important to see multivariable analyses to really disentangle the molecular testing data on prediction from the other variables. If there are associations with ultrasound features, how do those two work together to guide surgical therapy? If they are predictive of pathologic features and prognosis, how do the pathologic findings and the molecular work together? Are they independently additive in predicting recurrence or response to treatment? And then I think finally, we really want those further studies to evaluate if different treatments based on molecular testing really lead to improved outcomes without over-treatment. I will conclude there, and thank you to everybody, and we'll look forward to the questions here.
Thank you both for wonderful talks. Now we'll have some Q&A. And the first question is from Ali Al-Zarani. He asks, the baseline risk in this group in the study was 50 to 75% or 70 to 75%. But overall, Bethesda 5, we have this risk up to 75%. And about 30% of the patients in the study had negative results, right? In the molecular analysis. So the question is, how does this add to the diagnosis of cancer or benign features in this group of Bethesda 5?
Yeah, I can try and speak to that. So that's, that's why we did specifically look at this molecular negative cancer diagnosis. So yeah, you're right. High cancer prevalence in our group, and in this group that were molecular negative, yeah, it's 30 to 40%, cancer prevalence there. So, that was kind of part of what we wanted to look at was, is this a limitation of the test? That certainly is partly true. Is this also potentially a limitation of sampling? We're getting, in most cases, these are often either a dedicated pass or needle rinses into a preservative solution. And so it's a vial sample. There's no way to look at the, cytologic features in the vial. We're not making a smear out of it. So, is the sample that we are testing representative of the sample that the cytopathologist is seeing on the smear? And, in some cases, that's, we tested 8 of these 11 cases on the surgical and found that 4 of them, half of them had a clear identifiable molecular alteration. So that does speak to sampling as a, potential sort of issue in this group, and these, as you mentioned them, and, we would consider them missed cancers. So, then that becomes, this residual risk is high. Is anyone going to just observe them? Probably not. That's quite a high residual cancer probability. So that's, certainly the thought there is, if it's important to really fine tune that residual probability, again, in our cohort, it wouldn't drop it too much, but perhaps in other cohorts with lower cancer prevalence, maybe would be a little more useful. But the, repeat sampling, either a repeat FNA or we are able to test cytology smears. And so that was one thought. Unfortunately, most of the smears were from some of our community hospitals and weren't available for us to test because you have to destroy them and scrape the cells off of them. But certainly testing the cytology smear where you're seeing the clear suspicious for malignancy cytologic features would be an option to then say, okay, hey, we did identify BRAF V600E on the smear. Most likely the molecular vial was just not quite as representative of the lesion as we would hoped. For a couple of these cases, there were adjacent, there was one with a Hürthle cell adenoma very close to the cancer. Another one with nodular granulomatous thyroiditis right next to the cancer. And so grossly, it all kind of looked like one lesion. And so, you could see this right next to it. So yeah, but that still does raise a good point. If it's negative, what can you do? Even if you factor out the potential sampling issues and other things, even in a cohort with lower cancer prevalence, most likely you're still going to be left with significant residual probability. But of those few that were truly test negative on the surgical, those were all typically low risk. So the follicular pattern, follicular variant PTC, minimal capsular invasion, no vascular invasion, low risk ATA, low AJCC 8th edition stage. So, it at least gives you a little bit more information if you get all the way there that even if there is a cancer that we're missing, most likely it would be one of those low risk cancers. But then still the question, as Trevor alluded to, is, what do you do with that? Based on these results, no definitive conclusions can be made, but certainly something to consider and then hopefully look for in the future. But that's, I hope that answers your question. It was definitely a group that we were most interested in kind of exploring with this initially.
Yeah. So in your center, your center is a global leader in molecular changes in thyroid cancer. So in your cancer center, do you use molecular markers or mutations when deciding on the extent of surgery or radioiodine therapy?
I am not an endocrinologist or endocrine surgeon, but I did, discuss this with them, and I know they are starting to utilize it a little bit more. Actually, I believe there was a clinical trial that they just completed enrollment for that is exactly looking at that, is using molecular testing to guide surgical management. And so we're excited to see the results of that study as they are coming out, and hopefully will give us some good data there. But I know currently they are using it, and I know they are more frequently now using it in Bethesda category 5 as well.
Yeah. Trevor, the same question for you. Let's say you have a low risk patient or an intermediate risk patient, then they have BRAF or negative for BRAF mutation or any other mutation. How does it change the way you treat the patient? If any change at all?
Yeah, no, I mean, I think that if we think about BRAF in particular, it's easy to think of, right? In this study it was 57%. I think that's very in line with maybe 40 to 60% of what we would expect. And so for a papillary thyroid microcarcinoma that's intrathyroidal and maybe amenable to active surveillance, a lot of those are probably going to be BRAF positive. And so it isn't, I definitely don't think of it as can't be thought of as a sort of de facto marker of something we should treat very aggressively. We know from the large data that a lot of them probably aren't. I think, and so that, for example, wouldn't move me too much necessarily. I think in the, say, post-lobectomy setting, now you have a pathologic specimen and maybe it's BRAF for whatever reason. I think this came up the last time we were having a symposia. I think the opinions start to split quite a bit. But I think, as I said, really looking at what are the independent predictors are data that I'm still looking for. I just want to kind of go off of what John was saying and highlight, let's say that you had pre-surgical known mutations such as BRAF, and we know that's associated with lymph node metastases. And so you say, okay, well, we're going to do lymph node prophylactic level 6 lymph node dissection based on that. That could certainly benefit the patient, but it also opens up the risk of overtreatment and surgical complications. And so I think that's really where the rubber hits the road, and studies like the one he alluded to are exactly what we need.
Right. So a follow-up question. So I think there's pretty good consensus about the combination of BRAF mutation and TERT mutation. So in most cases, I think most experts agree that that would change the way we treat a patient. And in many patients, that's the only thing I want to know. Because if they have RAS mutation or BRAF mutation, I'm going to treat them the same way. If it's a BRAF TERT mutation, I'll treat them differently. So how do you think about this, John? Sometimes we want only one to know just one thing. So how do we do that?
Yeah, so I mean, that is something, there was a period of time we got specimens just for TERT promoter mutation testing from a group in New Orleans. So that's an interesting question. Certainly we do see in the cases that we had BRAF TERT, most of, those were a lot of the cases that did recur, cases that one of them became an anaplastic carcinoma. And I know this is something that, we've seen and talked about is then, what happens with RAS and TERT. If you're just looking for TERT, then, okay, great, TERT's there. And what does it mean? And so, RAS and TERT, these, Yuri certainly has some examples of these that historically were what he, has mentioned as benign metastasizing goiter, which is always fun. A large nodule, how thoroughly have you evaluated the capsule? And so then that becomes a question too. And I know there he and his lab are doing work as well. I think just getting TERT testing alone, if that's your one thing, what happens if it's an isolated TERT mutation? And the data there is a lot less clear. We see those, especially at lower level, and some of those I've seen, we get the data back and come back as, dominant nodule, dominant hyperplastic nodule. And so, then that becomes, okay, would getting just TERT result in overtreatment because you say, oh, TERT's there, it must be aggressive. Well, it's aggressive in combination with other things. And that was
right. I was asking about the combination, the BRAF.
Sure. Yeah, and that's definitely something, I mean, we think about all the time. Anything in TERT, that is definitely when we start to worry. And it's even for those like you mentioned, low, potentially ATA low risk or other histologically follicular adenoma, then what do you do there? And certainly plenty of case reports out there that RAS and TERT still can be and is aggressive, sometimes on a larger long-term time scale compared to maybe BRAF. But I think that's definitely something we're very acutely aware and always try and look to make sure is TERT here. Even sometimes is there a low level, especially in lower cellularity samples that we can deal with these sort of samples. So
thank you. So Mark, do you have questions?
Yeah, just one question, which is really along the same lines here. First of all, John and Trevor, great presentations here. One of the questions from one of our audience relates to the question of using molecular testing in Bethesda 5/6 to identify high-risk patients, and raising the question of how many of that subgroup was a surprise that did not manifest lymph node metastasis or ETE or even distant Mets here. And I think that's really along that continuum. My question really relates to this trend in thyroid surgery of staged thyroidectomy. And this sort of is an effort to, in some respects, overcome that. And so, I think that the questions here are to, will this help to advise surgery or active surveillance? But really the question is, in that subgroup who we ultimately would agree should have a total thyroidectomy, is this a better way to manage that than to take out a lobe where it's appropriate and evaluate really the whole picture? And so I think one of the questions here is really a cost analysis, because here we're testing all of these patients, and maybe John and Trevor, you can answer that question, because cost really wasn't covered here.
Sure. Yeah. I mean, the cost, I do not have a lot of the information as far as like insurance billing, other things. But I believe at least kind of the institutional build rate is somewhere in the like $1,000 to $2,000 range. And I know this came up at ATA, for patients where based on, ultrasound features, clinical, size, everything else, if it's a patient that you're going to do a total no matter what, maybe has a nodule on the other side, then what's it going to change? So I know that's certainly something, to think about with these, tests that are a couple $1,000s. And if you're going to do the same surgery anyways, regardless of what the result is, then, maybe, certainly that could be a consideration. I know we certainly tout, the predictive markers and potential therapeutic targets, but I know talking with our endocrinologists and endocrine surgeons, I mean, a lot of times they would prefer to do that sort of testing on a metastatic or recurrent sample anyways. So then maybe that loses a bit of its luster. But yeah, I mean, looking at the data from the high risk group, most of them, over 60%, had total thyroidectomy. Decent percent had central lymph node dissection, a couple prophylactic and a few therapeutic, and only 3 out of these 11 had even central nodal disease. 1 had lateral nodal disease. So it's, again, not as high. Not all of these cases in this high risk group were BRAF-like. So the RAS-like and others, we don't expect to go to lymph nodes. So then that becomes another consideration: is a RAS-like mutation even with TERT? What is there a benefit to lymph node, because biologically those don't metastasize to lymph nodes? But yeah, I think it's a good question, and I know there's been some cost analysis done historically with previous version of ThyroSeq, and especially Bethesda 3 and 4. But Bethesda 5, I think that's a discussion that our group has as well. Some people, Bethesda 5, do you still just go to surgery? If there's features that would take you to, guide your surgical management regardless, then, maybe that's a cost you don't need. And I think that's a good point, and always a good consideration to, not overburden the system, overburden the patient.
Okay, so one more question. So the question is, where are we going from here? Because we know how to test for many, many, many mutations. And for now, it's not good enough to tell us what to do in the operating room or when we use radioiodine. So how do you see the future? Maybe combination of molecular changes, maybe other markers of immune system, of growth factors, things like that. How do you and your group think about how to improve the prognostication of these tests? It's a difficult question.
Yeah, that's a tough one. I mean, certainly over time, there's only so many more molecular alterations we can identify. So I think that will be interesting with immune markers. But I mean, I think the big thing is going to be, one of these clinical studies that really tells us, what the benefit or lack of benefit is potentially in, guiding treatment. Does high risk need total thyroidectomy, like, has been alluded to? Do those patients end up doing better that we identify up front? And, then of course, some of that will be, well, would they have gotten total thyroidectomy regardless, as Dr. Erkin kind of mentioned as well. So, molecular guided them into total, but would they have had total regardless based on clinical features. So then that becomes kind of another point. But I think really that's the kind of data that we need, is to tell us, does it make a difference? Certainly we see the recurrence risk, but in the end, does it make a difference as far as changing management and then ultimately patient outcomes?
Okay, great. So we've reached the end of the hour. So thank you both, John and Trevor, for being with us. It was a fascinating discussion. Thanks, Mark. And we had a publication about the World Congress on Thyroid Cancer that will be held this year in London. Here it is. So you're all invited. And thank you all. See you next week.